Panelists, I hope you were listening to what Dr. Ya presented from the NHIS. And she gave a teaser into this discussion because she talked about innovative partnerships with private sector. And she mentioned some things that the NHIS is doing, and which is no doubt helping them to achieve more than other NHISs have achieved. And so I know a lot of what we discussed today in terms of innovation will be around partnerships, because we've been doing partnerships for many, many years. And the theme of this conference is aptly described as a new dawn of partnerships, because we want to see what can we do differently in the way that we partner. And so as much as it's called innovation, I already start seeing a recurrent theme about partnerships. But let me start with you, Vuyo. Reflecting on your own organization and your experience in Africa at MSD, what's the role of public-private collaboration to effectively increase access to women's health products?
Thank you, Daniela. So, as I was listening to Dr. Ya, she talked about some of the success stories of the NHI, including funding of vaccines to Ghana Health Service for Gavi or UNICEF procured vaccines. So I want to reflect first on that because that's actually quite huge and substantial. Gavi, the Gates Foundation Vaccine Alliance, procures substantial vaccines through pooled procurement from multiple manufacturers, including MSD. We currently supply about 24 countries across sub-Saharan Africa with our HPV vaccine through Gavi and UNICEF. And I think that is probably, in my mind, one of the greatest sort of health partnerships and innovations of the last few decades. Taking that pool procurement approach and procuring substantial doses for distribution across the continent in low and middle income countries. So that's the first one I want to actually refer to. If we consider the number of girls that were vaccinated on the continent with our vaccine last year, it was 13 million. Now, we only have 1 in 3 girls in Africa that have been vaccinated with at least 1 dose of HPV vaccine, so we still have a far way to go. But I'm really excited when I consider support we provided, for example, to the government of Nigeria in the rollout of their HPV program. And just to put it in context, 2022, we vaccinated 7 million girls across Africa. With the addition of Nigeria's program, we doubled that number in the space of 6 months. If we then look at other countries that plan to introduce programs, DRC, Ghana, which has also made announcements, Namibia, hopefully as well, we start to make substantial progress in cervical cancer elimination across sub-Saharan Africa. So MSD is incredibly proud to be part of that. In addition to that, we are starting to think around, given the fact that there are many more suppliers of HPV vaccines and the investment we ourselves have done in our manufacturing capacity, how we can vaccinate even more people going forward that are at risk. Women and girls above the age of 15, boys, so we can have gender-neutral vaccination. And we know that this can't happen necessarily through public sector programs. So now we're in the space where we have an opportunity to engage other health partners, other private sector partners, including big employers across the continent, to say, what can you do to eliminate cervical cancer sooner? Engaging as well private health insurers to say, how could we start looking at how you can reimburse vaccination for other at-risk groups? Because HPV programs have only been introduced across Africa in the last decade or so. That means that we'll start to see the quantitative effects in elimination in the next 10 to 20 years. But there are many women sitting even amongst us today that could still benefit from prevention. And so beyond our commitments in the public sector, we are ready to work and partner with the private sector and other players to really target that cohort of the population. Now, moving beyond vaccines to treatment, which is a really interesting topic, and I note my colleague next to me and some of the incredible work that Roche has done in Ghana. I think we should give them a hand again. When we look at the statistics, there was a pharma report that was issued in 2023 talking about the time it takes for new products that are launched in the US, approved by the FDA, to get to some of the most developed markets in Africa. On average, after a product is approved in the US, it takes about 5 years to get it somewhere on the African continent. Between 2012 and 2021, only 13% of all products that were launched made it to some level of public sector reimbursement in Africa. Now, if you consider the burden of disease, particularly when it comes to women's cancers, I don't think that's a statistic that we should accept or be happy about. There's no reason, in my view at least, and that's shared by all of us at MSD, that anybody who qualifies to have access to a particular treatment shouldn't have access to it because of where they live or their affordability profile. So I think for me, this is probably the biggest challenge of our time. And as we've been engaging with stakeholders in Ghana, we've learned about what some of our partners have done, like Roche. There's always opportunities to find some kind of innovative solutions, but a lot of it we find is linked to a specific partner, a partnership forged with Absa Bank, or a partnership forged with Africa Re, or Hanover Re, sorry, and some kind of reinsurance product. And all of these small partnerships, of course, make a difference, but they're still touching a cohort of patient that has a degree of affordability. And I think it's still not good enough. In my mind, we have so many issues that contribute to affordability challenges in the continent. A drug that I bring into Ghana at this stage, and I don't want to cause a ruckus, is subject to quite a substantial tax. We have the world's leading immunotherapy, pembrolizumab, in our stable. And if I bring it into Ghana today, already, even if I'm providing some kind of saving or access price, I've got that to deal with. Along the value chain, I've got distributors, wholesalers, dispensers that want to mark it up so that by the time it gets to the consumer, the savings I may have provided have been lost and are not translated directly to a patient. I think it's time that we start having conversations of this nature to think about how we have rational price regulation in our markets that actually ensures that life-saving medicines can be provided to consumers at lower prices. I also think that there's an opportunity. Many of our health systems, patients move between public and private. They might take chemotherapy because perhaps they don't have enough money to begin with in the public sector. Once they've saved up a little bit, they do some radiotherapy in the private sector. Then they need to have access to a biologic that is on tender or that is reimbursed. They move into the public again. The challenge, though, is that when we look at health authorities and how they manage health, they seem to think they manage public health. And I think we heard from the Healthcare Federation president of Africa this morning saying health ministers are here to manage health and not just public health. And I think that we're missing an opportunity to actually integrate our health systems and have governments procure with cross-subsidization from private markets. You know, the concept of social solidarity is one I think most of us are comfortable with. I am more than happy to pay more because I can, if I know that somebody who can't is going to access this treatment. And we're taking all of our out-of-pocket payments responsible for our individual health, and we're not using it collectively to support everyone, with those paying that can paying more and others less. And I think really if we want to start talking about increasing access at scale, we have to be deliberate about public-private integration and thinking about how we pool all of our resources in an organized manner. Thank you.
Yeah. Thank you, Vuyo. You've mentioned vaccination, and I want to take this question to Josatso. When we think about women's health, we have our pet subjects, right? We think about breast cancer, we think about cervical cancer, but do we consider the woman as a whole? And the global health direction led by the global health leaders, WHO, Africa, CDC, and the experts, is to adopt a life cycle approach. Think about the woman from birth to the time that they age. Are we having this kind of thinking in our policies, in our implementation, even in our drug development? What would you say about that?
That's a very good question you ask. I wanna defend pharma in terms of this. We tend to focus on the areas we're in and experts in, but that does not mean we're not aware of this greater need. Certainly, if we really intend to look after women in the way we say we will, we absolutely have to start from the beginning. And so varying companies try different parts of that journey. And so, in fact, what we're seeing as Roche, and Roche has both a diagnostic arm and a medicine arm. So I'm the medicine arm, for those who are wondering, and Dr. Alan Pemba is the diagnostic arm. And so we find for people like us, it's slightly easier in that when a woman is interacting with the healthcare system, my partners in diagnostics or even vaccines interact with that same woman, and then I'm able to take over all the way through to when they actually need medication. And what this really just demonstrates is, unless if your company is in the privileged position of having those two things combined, we actually do need to start entering into these multi-party agreements, because no one company on average can do it alone. No one government can do it alone. I mean, the NHI gave such wonderful examples of the work that they're doing, but they cannot possibly look after this entire economy by themselves. I heard an interesting statistic recently where they said for a country to be able to be sustainable, the healthcare of a country to be sustainable, you actually need on average more than 15% to be accessing private healthcare, the rest on a national unified healthcare like NHIS, and even then you'll still have an out-of-pocket market. So it's our responsibility to work together in a multi-partnership agreements with governments, with other stakeholders, other pharma companies, to ensure that when we're trying to broker these deals, what we're really trying to cover is to cover from when the woman leaves their home to try and access the healthcare system all the way through to when they get their treatment, and not just they, but the follow-up to that treatment, how they're looked after, and making sure that they stay alive long enough to be able to look after their children, send them to school, be able to be economic contributors to the economy, because that's what this is about, right? We want these women to be healthy and well enough to be able to come back into this economy and drive this economy, because the government certainly can't do it alone, the private sector can't do it alone, the NGOs that we work with can't do it alone. We're working at Roche on a program with Embrace, which she was here earlier, Antonana, exactly to try and fix that problem. We fixed one end of the problem, which is where we entered into a partnership with the NHI. We said, okay, the drug is available, here's the drug. To our surprise, not all the women we knew existed with this problem in Ghana were not getting the treatment. So then we started trying to figure out, well then, where are they? This is where people like Embrace come in. As it turns out, where are they is in the villages. Where are they is living at home, trying to eke out a living on the market. So they cannot actually leave their home, go to the hospital, leave the day, for the day, not feed children, not bring in an income and stay at the hospital. So where they're struggling is just even going to the hospital, even for medication that NHIA actually covers. They are unable to still access that medication. So we're working with Embrace to try and go find those women, find out where they are, believe it or not, give them some money for transport just to come to the hospital to get a drug that's already available on NHIA. That is the level of problem we're dealing with in some of these countries and the markets that we serve. And until we start thinking of the problem in that manner, we will not be doing justice to any of these women, or their children for that matter, because unfortunately for us, we know this. Once a woman dies, the trajectory of those children in that family is completely disorganized. And we are taking away people who would be able to contribute to the health and the economy of the country. And for us, we find that unacceptable. And that's why we keep, whoever's out there and wants to partner with us, really, we keep trying to find more partners to try and do this with. And Auntie Nana was actually saying to me, you know what, you're doing this wrong. You've got 300 partners. Bring us all together, tell this one, you're doing this for me, you're doing this for me, you're doing this for me, and then try to make it a one approach for everyone. And I really truly believe that is going some way into trying to make this a better, at least more organized road for that woman to travel.
Yeah. Thank you, Khadat. So, but I appreciate what you've said about, the continuum of care from diagnosis, from screening, diagnosis to treatment. But I want to, and I think I'll throw this to either you or Vuyo. Imagine a scenario where the burden of cervical cancer goes down and we start screening early. You're talking about all these countries that are adopting vaccination strategies in Africa. Are we thinking about 50 years from now? Are there things that will rear their ugly heads that are affecting women because women will suddenly start to live longer? Are we filling the pipeline of the things that they'll need in future with the kind of therapies that are available in the West but probably not being registered here? Let's not always assume that we'll fail. What if we succeed at what we're talking about right now and then we don't have therapies for osteoporosis, for other diseases that we know affect women? Are we really making that investment? And those investments and innovations have to first come from the innovative companies that develop these therapies. You need to think of African women needing those therapies. Do you have any comment on that, either of you?
Do you understand?
Okay.
So I think it's actually a really good question, Danielle, and if you think about it, that's sort of what's happened with HIV. We came together as the global community, we rallied our resources, we had a 90-90-90 strategy, many more people were tested, onboarded onto treatment, and now are adherent. And now they're dying of cervical cancer. A woman living with HIV is 6 times more likely to develop cervical cancer. And as the statistics are showing, with the NHI presentation, the ages of those women are exactly in that space of being economically productive and literally the pillar of the family. You're talking between the ages of 30 and the ages of 60. That's our most productive, those are most productive years. So what you said has actually happened. And yes, it can happen. I think the good news is that, as innovative companies such as, MSD, as well as I'm sure Roche, our DNA and bread and butter is developing solutions for unmet need. So we will always be investing in the next thing. And I think that if you look at the trajectory of health, life expectancy, and you look at Europe and developed markets, it already starts to give you a picture of the things that we really need to look out for. And in fact, we're living in a time with the huge emergence of NCDs just because there's been an increase in life expectancy, because there's been some economic growth and our lifestyles have changed. So I would say the conversation we have here today, and as we start to think about some of these innovative solutions, we need to create the building blocks now. Yeah. We didn't do that with HIV. With HIV, we just focused on HIV. But we didn't say, can we take the same approach for HIV and approach it and apply it to NCDs? And so as we have this conversation here today and we talk about partnerships and all these, public-private integration and all these solutions, let's have a horizon scan and let's enable learning so that we start to actually forecast the disease trajectory of the continent and our needs, and we've created platforms where we are able to actually solve for them.
Absolutely, absolutely. I couldn't agree more. For us, we're already thinking about these things. So we are currently, mostly in breast cancer and the other type of cancers, but we're already looking exactly at the data that we was talking about. And we've recently, I don't know if you've seen, purchased cardiovascular portfolios, because in fact that's what's going to happen next. Cardiovascular, diabetes, that's what's coming next. Because that is the nature of this work. You fix one problem and you find a new one that's waiting for you to get to work again and fix that one too. And really our commitment has always been to, and people tease me about our slogan all the time, but our commitment is doing now what patient needs next. Because we know, even if we fix today's problem, there will be a new problem. And we really intend to be there to meet that problem as well head on and try to fix that problem when it occurs. What we are aware of, acutely aware of, there's no way we can do this alone. I was fortunate enough to be invited to a breakfast by Japaigo, Chai, who else was there? There was quite a few industry players. And they were so surprised to see how happy I was to see my colleagues from Amgen and Novartis. And we're like, guys, you guys seem to think we love talking to each other. We're the only ones who understand our language. So please invite us together to these forums so we can do more. Because our whole thing is impactful escalation and impactful, because there's more than enough pie for everyone. We can only remain sustainable business when people are actually using our medication. And so for us, all of us actually, who are selling healthcare and who are in this healthcare space, we need to find these patients. We need a healthcare system that works. We need them to be able to access this healthcare system. That is the only way we remain sustainable. So we really are pro that at all times.
Thank you. Now, let me change gears from innovative products and come to Dr. Tursi, because I want us to talk about sociocultural factors that may impact women's uptake of interventions. I think you can mention what African Global Health does, and even in your own practice as a physician in Morocco and dealing with communities and patients. What are some of the cultural and social barriers we need to overcome? Sometimes we just talk to each other and talk about products, and Roche will develop a product, but we forget that there needs to be an environment where the woman can accept that intervention to make herself better.
Exactly. Thank you so much, Daniela. I'm really happy to be getting this question and not financing question and drug availability questions. I can't even manage my own finances. So, but I would like to say that women's healthcare has always been closely linked to our culture and social norms, especially in the African context. I think that the African context is not ready to receive ready and available strategies from Europe or from the US or anywhere else in the world. I think that we need to manufacture and we need to work on our own strategies, our own work, how to enhance the acceptability and the availability to people, to African people, to accept medication. For example, in my field, to accept that there is maybe a psychiatric problem, there is always maybe a need to get this medication. You were speaking about taxes and the problem of getting medication into countries. Lately in Morocco, we've had a big crisis in the availability of some very important medication, some of which are psychiatric because, of course, this is what I use mostly, but some are also thyroid medication that people had to go abroad to get. And we know that many women are diagnosed with thyroid problems. And this is something that affects not only the physical health of women, but also their mental health. We can see fatigue, we can see discouragement, we can also see depression, that it's not just a normal depression, but due to thyroid problems. This medication have been missing from the market for over a year, and it's all due to taxes problems. We also do not have a big availability of psychiatric medication, and you have to understand that Morocco is 14 kilometers from Europe, so from Spain, so it's not very far. So when you see how hard it is to get very important medication, very important injections that have been present in the market for a long while. Actually, I think you would have more the answers, and you answered it a little bit earlier. So when we speak about the cultural norms, I think that women in the African context, they're not used to go seeking help. They're not used to reach out. And we as psychiatrists, we see this side of women because they come to us to tell us about their problems, to tell us about what they live through. Some women go to gynecologists without speaking to their husbands because they don't want to be judged. They don't want to be judged by their families. They don't want to have this look on them that they're incomplete, that they cannot perform, that they cannot be fit women, fit wives. And this is such a shame, because when we were talking earlier about he for she, I think there is no improving women's health care without improving the perception of men to women health care. This is such an important matter. That's why we should educate people who hold the microphone, the community leaders, people who can make a change. And well, let's face it, many men hold the microphone. That's reality. So these men need to be more sensitive and more sensible about these problems. And I think that's how we can use that and improve that. And about the cultural norms, you know, in our country, a lot of people prefer to go to somebody who does religious practices instead of going to psychiatrists. Okay, this is not something that is frowned upon in our context, because if we eject these people and we tell them that you do not have a role in helping patients, I think we're going to lose all the patients. That's why we should integrate traditional medicine, traditional care, because it is important. Maybe it can be a placebo effect, but if it helps, I think we should consider that and integrate everything that's traditional to evidence-based medicine and to work together, especially in our context.
Okay. Now, Sarah, I'll ambush you with a question that we had not put in the guide, but I can't resist because you're a psychiatrist. And I had talked about forgotten areas, you know. We have our pet subjects and they're important. But what's your view on whether we are giving enough focus to women's mental health?
Well, I think that we always stigmatize women in being the crazy ones. Yeah. Women is easily put in a box, and I think that it's the same thing. Women and men's mental health are both important, and I think particularly in mental health, I think that men don't get enough attention in mental health, because we always say that men are strong, they don't have the right to cry, and women are more fragile. But still. I mean, the problem with women's mental health is that we do not give credit to how strong women can be. Women go through postpartum depression. Women go through postpartum psychosis. We speak about baby blues, which can be just a passing period of time, but it's hard on women. This is something that maybe many people don't understand. Many husbands, many families don't understand. When a woman, after giving birth, is down, cannot give care to her children, we see many more severe cases where it's more violent. Women get to be more violent toward their children. So that's the kind of education we should give to couples. Now couples go to doulas, they prepare the birth, they do many practices. So why not go to therapists? Why not speak about this? Why not prepare for how they're going to feel after birth? Prepare help, prepare nurturing, prepare, everything that can maybe just limit the severity of the baby blues.
Okay, thank you. A final question for the innovative companies, the R&D companies on the panel. It was raised in an earlier session, and I wondered whether they were reading our script. Are we including women in clinical trials? Are we equally represented in the R&D process? Because if we want to develop innovative products for women, then we have to include them in the research. So maybe first.
May I start?
Okay.
So yes, actually, interestingly enough, if you look at at Roche, that is, our oncology department, well, our clinical department is mostly oncology, and if I tell you it is 80%, 90% staffed by women, you wouldn't believe me. But this is in fact a reality of what we're doing. But even more importantly, I mean, for us, we find that if you don't actually include even underrepresented women, the quality of that data will be useless. So Roche and a couple of other actually industry partners, I tried to list them down and forgot the list somewhere, GSK, MSD, quite a lot of us have actually gone into a partnership, and we're all working on something called the Africa Genome Project. Most of it is happening in South Africa at UKZN, at the University of Natal, and what they're doing there is they're actually trying to add the number of black women and men into global trials, because the reason this partnership started was when they actually reviewed the number of trials the world over, they actually discovered that the African genome only exists 1% of all global trials, which was shocking, I think, to everyone, because no one had been actually measuring this matrix. And then when we discovered that this is such a big problem, I think a bunch of us who were already running these trials couldn't believe that we'd missed such a big, important part of the genome project. So a few of the partners have joined. Some of the work started. I know there's something happening here in Ghana in June. There will be some partners joining. We will publish some of this data when it becomes available. Because in fact, you are correct, completely correct in saying there is no way you can make products for women without involving women in them. If you haven't actually considered their views and what they think is important, you won't be able to actually account for it. So at Roche, certainly, not only do we employ them, but we definitely are including them in our plans. The one thing I would like to ask in this forum and to plead with people like the FDA of Ghana is to please support us in trying to bring some of these trials into the country. We currently have one trial in breast cancer at Roche currently, but throughout Africa we have over 20 trials happening. And some of the reasons some of the trials are not as fast here in Ghana versus South Africa, for instance, is just the strength of the FDA and the clinical processes that are being run. So on behalf of Roche, we have most of our centers set up in South Africa, Kenya, and Morocco, but nothing here in this middle belt. So being very determined in trying to make sure that that picture changes. So we've included in this last trial Cote d'Ivoire, Ivory Coast, Cote d'Ivoire, Ghana, Nigeria, and any of the other countries that we're surrounded. But some of this, and the reason we aren't always able to do as much as we want to, is if the actual governing bodies that are in charge of some of these things aren't set up with all of the rules, it makes it that much harder to come into this market. And so we tend to defer to the markets where there's already a plan already in place. And so that would be my plea and my ask, that if we can work together with some of these partners to try and really strengthen this healthcare system, because then more can definitely be done.
I'll try and be brief. I mean, she said it all, but what I'll add is, I think people underestimate the impact of clinical trials even from an investment perspective. Over the past 4 years, we have spent $40 million in research and development in sub-Saharan Africa through our clinical trials. Over the past 10 years, we have had over 1,250 clinical trials in sub-Saharan Africa, predominantly in South Africa, for reasons that Potatso has mentioned. But we are expanding our clinical trial footprint now to Kenya, Uganda, Mauritius, Botswana, and hopefully to West Africa soon as well. But 100% clinical trial diversity has become such an important issue for our global organization. And to the extent that our commercial business is actually smaller than our clinical trial business in South Africa. We have a big campus. About, of the 240 plus of us, only 80 are in commercial. Predominantly, they're in medical and our global clinical trial organization. So it gives you an idea of how important clinical trials and research is to us. Interestingly, we are actually one of the top 5 clinical trial sites or regions in our global clinical trial framework within global MSD.
Yeah.
So you know, that's really something that's important to us, and we're super committed because it not only allows for diversity, you know, like in genome and understanding the particular epidemiology and efficacy of our products in our settings, it also expands access. One of the other things I will mention, just my last pitch, is when we do clinical trials, what becomes important from an ethical consideration is if we will commercialize in a market thereafter. And so it does become important because we can't leave patients that have been benefiting without options once the trials are complete. And so really addressing the access issue and finding innovative solutions to enable access to markets even becomes important in ushering in that R&D component into market.
Thank you. I hope the regulators in the room, I had seen, thank you. I had seen Ghana FDA. I hope they can make a comment on how, you know, what they're doing to make sure that clinical trials can get into the country so that African women are included. I'm going to open up for questions now, just a few questions for our panelists. If the ushers can help me take the mics round. I'll take 2 or 3. There's one there. Say your name. Say your name, your organization, and your question. Who will ask the second question? Dr. Desai. And then we have one back there, and that will be the last one. All right. Go ahead.
Okay, thank you so much. My name is Dr. Omar Fall. I have a question for Vuyo about increasing access to vaccine in Sub-Saharan Africa, about the private sector. We have a lot of challenges in terms of access. I mean, in terms of access geographic, in terms of countries, in terms of pricing, in terms of supply chain. What are the best strategy to solve this equity between the public and private sector? And I need to better understand what is the percentage of people for private sector about vaccine in sub-Saharan countries. Thank you so much.
Thank you.
Thank you, Dr. Desai. Vuyo, you mentioned the pricing, that by the time the manufacturer, innovator makes a product and ultimately reaches the client, there is a lot of issues that go on, and obviously the price to the client many times is much higher, and this is the reality that we face. So again, I'm going to ask a similar theme. How does the private sector come in? How through AHF, for example, and the bodies under AHF, the different federations, how is it possible to work out pricing that, say, for example, we put an MRP, a maximum retail price, and that's all you can charge and nothing more than that? Are there bottlenecks to doing that? Or is it a possibility? And how can that be achieved? Thank you.
A few rows behind you. Yeah.
Thank you. My name is Ntombi Sikwebela. I'm from Find Diagnostics. I'd like to first thank Vuyo and Khutazo for the excellent work that they're doing, and especially to Vuyo to congratulate MSD for the high volumes of HPV vaccination, reaching so many countries, and I'm really excited that hopefully in the future we're going to see the prices coming down, and that more countries will be able to access the HPV vaccines, because the higher the volumes, we should be seeing the prices coming down. And then I also wanted to remind everyone that the prevention comes both ways, in two ways. As we vaccinate the younger ones, we shouldn't forget that there is a gap, in that a lot of us in this room missed that opportunity, in that when we were growing up, we didn't have an HPV vaccine. But we are fortunate enough that at our age, we now have HPV self-collection. We can collect the specimens ourselves. We don't even have to go to a doctor's room or a nurse's room to be able to do the pap smear, as we see already that in most instances, the uptake for the pap smear is very low. In the previous session, a number of reasons were stated, but in most countries, we don't even reach 40% of women coming forward for pap smears. It would be good if we all started talking about the availability of HPV as a screening test, because it is available. I know that for most ministries of health, the cost is a challenge, but once again, there are opportunities. And one of the opportunities is a lesson that we can learn from the HIV program again. And it also talks to addressing the cultural barriers of difficulties with talking about sexual health. In the HIV program, they use the mother-daughter pairs in order to be able to talk about sexual issues. With cervical cancer, we also have the same opportunity because we are vaccinating the young ones. There is maybe an opportunity to screen the mothers and the older sisters and the caregivers of these young girls at the same time. But we don't know if this is possible, because we are here today to talk about the new dawn of partnerships. How about Roche, who makes the self-collection test kits, and MSD, who provides the vaccine, and the Ministry of Health in Ghana are working with FIND to try and see whether it is feasible to try a similar approach to that is being done with HIV, looking at whether culturally and in many other ways it would be possible to use a similar approach of integrating the HPV vaccination with an HPV screening program for older women.
Okay.
If that works, then we would be moving forward. Thank you.
Okay. We have a question. And then we'll wrap it up.
Thank you very much. And I'm very excited about the collaboration I'm seeing between Roche and MSD. I think that one thing that is obvious is how, I must say, MSD, you have been able to move most countries in Africa forward rather than waiting at the back of the queue when it comes to the HPV vaccine, contrary to what we saw in the COVID days. And I think that we'll continue to push the advocacy and make sure that the prices and the availability, even of the non-valent, is available in countries. One of the things that I will say is that, for example, in Ghana, there has been a lot of things that we have learned in public-private partnerships, different models, including private-to-private partnerships. And I think that we should be able to deploy these and help within this area as well. I happen to have managed large-scale HIV programs, and so the examples that we are drawing there, including the public-private partnership models that have remained sustainable since 2008 up to today, we can be able to deploy some of them. One of the things I would say as we look at our partnership with private and public, is how we can be able to make clear investment cases and be able to optimize whatever resources we're going to get coming through, either from development partners or big pharma or private investments. I'm saying this from the backdrop of optimizing and making impact, and we thinking about the population and scale up. Because for private sector, we interface a lot with government. We interface with politicians. And this, for me, having participated in different areas of this, sometimes is of concern in terms of how we utilize resources and what really, at the end of the day, the impact is like. Because you can see a small program, small money, making a lot of impact, having the same value chain and systems. And you have sometimes a lot of investment through a different pipeline, using the same kind of expectation that you have, but then impact is very low. And so I would say that as we look at our partnerships with governments and with any, let's think and make sure that we can optimize the resources to get the programs running at the community level.
Thank you so much. I'll ask my panelists to reflect on the questions and answer as you give your parting shots. We'll start from Khozato, but let me just give a summary. We have a question around, thank you. We had a question from Dr. Omar Fall around equity, especially thinking about the vaccination space. We had a question about how private sector can help the MNCs to lower the price, the issues of margins and so many iterations of adding price, and finally the customer, cannot afford, what partnership can be there between the federations and the manufacturers of the medicines. It doesn't always have to be perhaps government bringing in price controls. Somebody brought up the issue of self-collection HPV screening, which is a new modality, as they are working together, programs working together with vaccination programs for this. And I like the last point that was brought up about we have minimum resources, but how can we achieve the highest impact? So as you answer those, just give your parting shots, and we'll just do one round and close it.
Good. Yeah, I'll try to keep this brief. So in terms of equity, Roche has already been thinking about that issue. And in fact, what we do at Roche is when we think about pricing, we actually do differential pricing depending on the area. So we look at the World Bank's GNDP, and then based on that, we give you different prices for different markets, because we're very cognizant there is no universe in which you can ask the patient in the US and Europe to pay the same as a patient in Africa. So that's how some of the ways in which we're able to be flexible on the price, depending on the market we sit in. The other thing that's really worked for Roche in terms of being able to control that price is we actually moved here in Ghana from having a third-party distributor to a direct market, because then we found we're much more able to have control over that price and to make sure that the price we actually are giving is a price that the patient actually gets. And that's allowed us to have these partnerships with the government and any other payer who's actually paying, because we can then do those agreements directly with them. So that's really helped. And in terms of that screening, absolutely. I think one of the things I was told to say by my team for sure is to say we are definitely open to having impactful partnerships. We have definitely seen impact in the partnership we have with the NHIA. We have seen impact in the partnerships we're having with teams like Embrace, partnerships. We have so many partnerships, and really maybe the thing to do is move away from these bilateral partnerships into more multilateral partnerships that really ensure that the work we do has impact for the people we mean it to have impact to. Because at Roche we take it very seriously that what Vuyo said, where you live should not determine what type of healthcare you get. And that's something we take very seriously. Thank you very much.
Okay, so agreed in terms of how to start managing. It's a complicated question because everybody in the healthcare ecosystem is important. There needs to be win-win. So everybody must be profitable in a way that's obviously ethical. So I don't have the answer specifically on how we solve for it, but I think you maybe have given us all homework. Maybe that's something with the Africa Health Federation that we need to start applying our minds to. Okay. I will say, in terms of partnerships, we 100% agree. I'm really happy to be sitting here next to Khothatso because of all her partnerships, it means I don't have to establish all these renewed relationships. I can just insert myself as another partner. And I think that's good because we operate in some areas in the same place and others not, but we're both very involved in women's cancers. And we have complementary product portfolios where we can absolutely collaborate and bring both of our resources to bear. So thank you, Find, for the offer. I think you've created a picture of what a working group could be. Now you need to, do the constitution and convene us. I'm very happy to participate. The last point I'll just speak about, the private market versus public. So it's an interesting question and it differs from country to country. Generally speaking, because of our affordability levels in Africa, the split between public and private, say, is like 80-20 public, 80-20 private. But in actual fact, if you start looking at healthcare expenditure and trying to figure out how much is actually out of pocket, there's disagreement because some say it's 60, some even say up to 90%. And so I could argue that potentially the private is larger, and the problem is that we are our own health insurers, which is huge problems, right? So the private market is huge. The big challenge for us as multinationals that operate globally, mostly in countries with universal health coverage, where we're negotiating reimbursement with national health payers in resource-rich countries, is we're used to engaging in that way. We're used to pricing for that. But in Africa, we need to look at it slightly differently because I can't ask, you as an individual to pay so much when a government through a public procurement process is paying so little. And so those are things that we're still trying to grapple with, but it is something that we're looking at, particularly when it comes to vaccines, because in the private market, it is out of pocket. And that is an important consideration. You have to ask yourself, am I buying the bread? Am I paying the school fees? Or am I seeking help when I'm not even sick? So, important question and something that we are really actively thinking about and trying to find solutions to. I'm very proud in terms of the nanovalent that you referred to. MSD has participated in the pilot project for Africa Medicines Agency. We have submitted a dossier for our nanovalent vaccine, and we're hoping that within the next 12 months it will be registered in multiple African countries. So we put our hand up for that, and I think that's super important to push access forward. And just to address one misconception and clarify. Up until this point, the general focus for cervical cancer prevention has been on girls between the age of 9 to 14. That is because, as we think about it from a global health perspective, when you think of limited resources, you want the biggest bang for your buck. And so that is the young girl. It doesn't mean that many of the vaccines available are not efficacious for older girls and older women, and that they're not relevant for boys. So, as the supply situation changes and more are available on the market, we have to drive vaccination and prevention efforts across all at-risk cohorts. And so the opportunity for cervical cancer elimination is bigger than it has ever been today. And that's why we're really trying to grow this. And I will end with that. Thank you.
Okay, so I have nothing to say about HPV, but actually Daniela asked me about if we had self-administrated tests of HPV in Morocco. No, we don't. We do not, unfortunately, and the vaccine is also available from ages to 9 to 14. The problem is that also we lack awareness in that matter, and many girls who live in rural areas especially, they do not get the vaccine. It is not considered as mandatory, and of course there is no awareness about getting tested after your first sexual encounter, and that is also mandatory. So I think we have a lot of things to do, a lot to go, and of course we would love to have partnerships like yours in our country, because I think that this is a field that is really not explored yet. Yeah.
So allow me to thank my panelists and challenge them to take on the ideas that this crowd has put to you, because for sure at the next Women's Health Conference they'll see you on stage and they'll ask you. So thank you very much. Let's give a hand to the panelists.